Okay. So I just wanted to say welcome. This is very exciting. The Southeast Brain Spotting Institute is one one of our key missions is to help to educate people who have been educated in brain spotting, but to deepen your education. We also have the mission to help spread brain spotting as far and as wide as it goes. And I'm so happy to see so many people from all over the world sharing this time with us. So the second Thursday of every month, we do a lunch and learn like this, and we normally have a donation fee or it's free for our members. However, this time, in wanting to honor and to support everybody with COVID-19 challenges and the topic being around pain, we've opened this up and giving this out to the community. So Beth Medina, who's here, is one of our vice presidents, and she is recording it. Heidi's here on our board. I'm not sure who else is here. I have to scroll through, but maybe you can unmute and shout out.
Hi, I'm here, Stephanie.
Oh, hi, Stephanie.
Hi.
So anybody else on the board here?
Emily is here, I believe.
There's Emily Moise Fournette, and she is here, and she's also our vice president. So thank you guys for showing up and being here. And no further ado, I'm going to turn the floor over to Erick Sandstad, who is a licensed professional counselor in now Georgia and Kentucky. And he has a wealth of knowledge and experience with a long extended bio that incorporates many different modalities, including Gestalt therapy, CBT, reality therapy, and the list goes on, but it definitely includes brain spotting. So welcome, Erick. And one other thing I wanted to say is Erick put in a proposal to talk about this at the international conference. So this is a great preview, and the international conference is now going to be May 28 to 30, with the pre-conference May 27. All those that have been enrolled, it's going to roll right over to next year, 2021. And those that aren't, we invite you to sign up. So take it away, Erick.
Awesome, thank you. I'm honored to be here. I'm going to be talking about a subject that affects a lot of people. And I want you to start by touching your ear and pinching your ear and notice what you feel when you pinch it. So that's what we're going to talk about today, because it's the sensations that we perceive in our body. And I gotta put it in context. So I work for an agency in Somerset, Kentucky. And as you all know, when you work for a community agency, you get all kinds of people and you don't have much time to work with everybody. So this gentleman came in, he must have been in his 40s. I'm gonna call him TH. And he walked in the door, and it was my first time that I would meet with him. He was much taller than me. I'm only about 5'7", but he was like 6'5", and I looked like a little Frodo next to him. This man, when he walked in, he was carrying a cane, and he was walking on a cane, and he could barely walk to the office. When he got in the office, he was in excruciating pain when he sat down. And then all of a sudden, my intuition at that moment is I felt for him, but I had just met him, so I couldn't do anything about it. All of a sudden, we started working on the intake, and he couldn't focus. And I get these intuitions, because I'm connected. I feel like his pain is affecting me as well at that moment. And I realized I gotta do something. And the first thing that came to me was, let's use your eyes. And the procedure that I'm going to teach you today, that I'm going to show you how it works, it affected him in such a short period of time. We were probably maybe 5 minutes the most. And his reaction after this procedure was, are you a fucking wizard? What the heck did you do to me? And And I was like, oh, it worked. And so I was so amazed. So he was so excited. He was like, what did you do to me? So think of it like this. This man had a kneecap that he had been replaced in surgery at the University of Kentucky Medical. But the kneecap was so small compared to his knee that every time he walked, it rotated around his knee. And so the excruciating pain that it was so much. And then all of a sudden, he's able to stand up and he's not feeling anything. And he's like, oh my gosh. He says, I can't stand up and I don't feel anything. So I was elated at that moment. I'm thinking, what happened here? How does it all make sense? But I decided I'm going to think it over. I'm going to see how he's going to be at the next session. And sure enough, he came a week later for the next session, and he was still claiming that he was having such a comfortable moment to be able to walk and whatnot. So within this introduction, I want you to think of this. I want you to think of pain as having two facets of it. What I call it a standalone pain and an entanglement pain. And I'm going to describe the differences. So think of the experience that is associated with other emotional neural networks that are found maybe like in the childhood adverse experience questionnaire, for those of you who are familiar with it, called ACE. That will be called an entanglement. So entanglement means your neural network associated with the perception of pain has entangled with another neural networks from the past, emotional, maybe trauma, maybe neglect, maybe humiliations, etc., etc. So that's entanglement. But when the experience of pain is not associated with any other neural networks, such as a standalone, like this gentleman was, TH, then we call that a standalone pain. Let's define pain, because to me, pain, up to not long ago, it was considered what we call Cartesian pain, where pain resides in the affected area of your body. So if someone runs over you and on your toe, like a skateboarder, and someone runs over your toe will hurt. So the perception back then was, oh, the pain must exist in your toe. But now we're coming up with a whole new definition of pain. And the definition that I use, it comes from the International Association of Study of Pain. And it says that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or describes in terms such as damage. So we're getting a whole different perspective here. Now we're associating sensory and emotion. Then there is a professor, and I think he wrote a book by the name of Bruce Amer. And he decided to come up with a different definition of pain, which I still feel like it's very accurate, in which he says that pain is an unpleasant bodily experience that feels like something in the body has been or is being damaged or destroyed, perceived or expected as a threat to or interference with one's ongoing functionality, and that is associated, now we're going back to the association, associated with emotions such as fear, anxiety, anger, or depression. So now, this definition now, it recognizes that pain is a subjective experience, that it contains a mix of sensory components and an emotional belief component. And these two intertwine in the experience of pain. Now, this is so interesting because if you, I'll give you an example. So those of you who know Kara McGill, Kara, and it's my beloved one. Her daughter was having an experience of some reaction to her body, and we took her to the place where she was going to be examined. And the first thing that the nurse said to her was, "This is going to hurt. This injection is going to hurt." And I'm thinking, please don't tell her that. Please don't tell her that. Because sure enough, as soon as she was going to put the injection on her, she started like feeling overwhelmed with emotions. So the association of pain with the emotional component has merged. And I felt like our duty or our responsibility would be to understand that we need to separate the two components of it, so that people will be able to understand that, yes, I don't need to have the emotional component if it's not needed. Pain is one of the most ancient tools of interpretation of stimuli from our nervous system that has endured until the present time. And I see as pain as an alarm. So this alarm mechanism that has alerted us, from our primitive nervous system, it has helped us stay in this planet in order to avoid danger, in order to repair tissue, and to survive for over a billion years here in this planet. And so without this internal alarm, we will have disappeared long ago. And so that's why I feel like when I talk to my clients, I want to make sure they understand that we don't want to get rid of anything. We just want to be able to understand it and accept it in such a way that we know that it's trying to help us. So pain is trying to help us, it's trying to protect us from something. The subcortical regions of our brain are constantly scanning our body. And they are constantly receiving stimuli from receptors in the skin and our organs. And because it's scanning for irritation, scanning for damage. But what I notice is that the alarm system could be a little bit oversensitive and might be scanning too much sensations. And it might easily get stuck. And then all of a sudden you're sounding danger, even long after the repair has taken place. And I love a quote from I think she is a psychologist by the name of Kate Thompson. And she has this beautiful quote that says, when pain is a warning signal that when everything that can be done and should be done and has been done, there is no reason for it to continue. For this reason, by asking your client to tell you a little bit about the history of the relationship of pain is very important. And especially with individuals who have chronic pain, we want to take the time to discuss their views about pain, their patterns, their beliefs about pain, and especially focusing on how these beliefs have served the client, and maybe there's a secondary gain, or maybe there's a part of their personal identity, or maybe it's an attachment to pain that they might have. And so we want to be able to understand them and be with them wherever they are. One of the instruments that I use for this is the McGill Pain Questionnaire, and it's free. You guys can find it, a free copy online, but I also will attach one when I'm done with this presentation, and I will give it to Cynthia, so Cynthia can make it accessible to everybody as well. But the McGill Pain Questionnaire facilitates an understanding of what pain means to the individual and their history. And so that's a good way for us to sensing, oh, okay, so that means that you do have an attachment to pain, or at least the benefits of it. The problem is not pain. The way I see it is that the valuable alarm system in our bodies don't need to be on all the time. especially if we already seeking treatment. And so when a client comes to me and he or she is already seeking treatment and it's already being treated, I tell them there's no need for you to have the alarm going on because you already know and you're already doing something about it. And I use the metaphor of the alarm, the smoke detector in our kitchen, that you guys are cooking or I'm making some toast and I use the toaster and all of a sudden I go take a shower and I forgot about the toaster and I'm on my way to the office and oh my gosh, now it's like smoking and the smoke detector is going on and on and on. But the only thing I got to do is open the windows, air it a little bit, change the toast, put in another one, but the alarm's still on. So we don't need that. And so I tell my clients, sometimes after what we have done everything and we already know that there's no need for it, we just got to disconnect it or we just got to unplug it or whatever we got to do. So the same thing with pain. If we're already doing something, let's not continue with it. But at the same time, we want to be careful because with pain, especially when it has become enmeshed with our emotions from the past, especially if we have had adverse trauma and emotions, we want to be careful so that we don't come to the rescue of our clients right away, and we want to help them get rid of pain, so that we want to stay with them, and we want to be very patient so that we don't assume that they are ready to disconnect the alarm, so to speak. So once your client understands the premise and you have educated in their subconscious mind that pain is an alarm system and it's just trying to help you, then I go to the next step, and this is very crucial. So in my experience, I've learned that our brain is very logical, especially our neocortex area. It's very logical. It's trying to find the opposites of what we do, the consequences of what we do, cause and effect, etc., etc. So if I ask any of you, what's the opposite of pain? So like, let's just say I ask my client, so you're in pain? Yes. Okay, so what's the opposite of pain that you need then? Oh, pleasure. The opposite of pain is pleasure. But notice, because pleasure, we don't necessarily trust pleasure. We think of it as, it's suspicious. So if the logic in our neocortex is that what I need is pleasure instead of pain, our body is not going to accept that. So I like to think of it as, let's give a different name to pain. And I like the word discomfort or pain, because I have found out that whenever we make neural network association with pain, we kind of have attached to the word pain those neural networks. And the moment that we begin to think of a different word like discomfort, especially if discomfort doesn't have neural networks attached to it, then we're distancing ourselves from it. So I ask my clients, okay, so if let's get rid of the word pain from now on, and we're just going to call it discomfort. So tell me, what is the opposite of discomfort? And the logic says comfort. And then my next question is, what does your body need? Comfort. And then I say, perfect. We are ready. We're getting ready then to begin our treatment. And then one final thought that I share with my clients is, we have to see the big picture. And in the big picture, we're made out of, all of us, of 50 trillion brilliant cells, right? And we have these neurons in us that are doing all the work for us. They're brilliant. And each of these cells have their own memory. They remember everything. If you have read Peter Levine, he talks about the body having memory. And therefore, one of the things that I assure my clients is that before we begin this process, we need to know that the job that we have to do is just help ourselves remember what comfort level there used to be in the body before the discomfort appeared, before it was damaged, or before it was irritated, or whatever happened to us. And therefore, the neurons that have fired together remember when they were wired together in the comfort area. And I tell my clients, and we're going to all do all this through our eyes, by finding the spot that accesses this memory, because where we look affects how we feel, including physically. So now I just set the frame for all of you, and I'm going to talk a little bit about how to go and what I did with the client TH. So before I begin with this, one more little thing. 2017, I went to Spain, and I went to visit a physician in Valencia by the name of Dr. Ángel Escudero, who has performed over 700 surgeries without anesthesia. I was curious. So I went there with my mom, and we interviewed him. I spent an afternoon with him, and I wanted to pick his brain, because the gentleman is already in his 80s, and I figured out I gotta learn about what he has done in order to do all these surgeries. And his answer was very simple, and it made me a little bit upset, because I went all the way to Spain just to hear a very simple answer. But nevertheless, it has a lot of wisdom. And he talked about our saliva. And he said that he always, before he began his surgeries, before he would train people on how to control their pain, he will ask them to have saliva in their mouth, because saliva will be the sign that we are in a ventral vagal response, and therefore that the connection between the neocortex and the subcortex areas of the brain are talking to each other, and increases the chances of having faster analgesia. So because of that, I always ask my clients, do you have saliva in your mouth? Is your mouth dry? And if they tell me it's dry, I said, take 3 deep breaths and just tell your brain to give you some pure saliva coming into your mouth. And in fact, I want all of you right now to do this. So I want all of you to take 3 nice deep breaths, but from your diaphragm, and just ask your brain the following. Okay, so take the first nice deep breath. Another one. And just say to your brain, in the same way that when I drive a vehicle, if I turn to the right, the vehicle goes to the right, or if I turn to the left, the vehicle goes to the left. In the same way, I want you to give me fresh, clear saliva that is coming into my mouth right now. And so just notice if you're getting a little bit of saliva. And so this is how I start with my clients, just to say, okay, let's get a little bit of saliva. Once we have done that, then I ask my client, okay, tell me about your discomfort right now from 0 to 10, using your thoughts. Tell me your current level of distress. And let's just say they say 8. Then I ask my client, does this discomfort serve you in any way? No. Would you be willing to welcome some comfort into your body? That's the next question. Yeah. Okay. So here we begin with inside window brain spotting. So I ask my clients, I want you to go back to a pleasurable, and this is a key word, pleasurable memory. I'm not asking for comfort, I'm asking for a pleasurable memory when they were active, maybe outdoors, while playing, hiking, or taking their pet for a walk, when their body or that affected part of their body felt very comfortable. So in case of TH, I just said right away, tell me the last time you noticed your knee and you were doing something with your knee and you were having a pleasurable or wonderful time with your pet or with your family. And he said, oh, I was walking in the park and I was throwing the frisbee at my dog. Oh, perfect. So just notice that. So once we have that memory, then I ask the client, would you mind finding the spot that you can feel more connected with that? So then that's when I pull my pointer and I ask, okay, notice the spot. Is it more here? Is it more in this direction? Is it more in this other direction? And so we want to be able to find a spot for that. Once we find the spot, the memory spot for that memory, that pleasant memory when they were using their body and they were comfortable, let's just say the client says that is right here. So then what I do is I use advanced Z-axis. And so with TH, I ask TH, okay, would you mind letting me know and notice what happens in your body when I move the pointer slowly and closer to you or further away from you, and notice what happens to the comfort or the discomfort in your body. And so with him, it was obvious that when I move it away from him, he said, oh, it feels good. So I knew that moving it away for him, it was a good sensation. And moving it closer to him, it did not feel good. So immediately after that, so once I knew that that was the so to speak, the thoughts were feeling better, I asked the client, just stay with your body sensations while thinking of the pleasant memory when you were throwing the frisbee, and just follow the pointer. And so I let the client process in silence as I'm moving the pointer very slowly. And you guys have seen David do this in trauma resolution. So I just do it very slowly, and I do as many sweeps as I can, and I take it as far as I can. Sometimes I need a much bigger pointer so that I can reach as far as I can. But I ask my client, notice any body reactions, and I don't interrupt. So it's at the end of various sweeps. I ask them, notice if anything has changed. And as I repeated this process with TH, that's when he started feeling that something had changed in him. So it was very simple. This is what amazed me of the simplicity of just using advanced Z-axis on a comfortable, pleasant memory when he was using his knee. And this is key that I learned while I've been doing this for quite a bit with other clients. And when I tell them, sometimes they don't want to get their SUDS all the way to 0. So sometimes the SUDS are comfortable to them, even if they get to a 5 or a 4 or a 3. And maybe that's all they need. So I ask my client, as we repeat the process of the Z-axis, let me know when you have arrived at your ideal SUDS level, when you feel comfortable enough and you want to stay there. So like with this client, I think he went up to 3 or 4. So he didn't want it all the way to 0. He was pleasant just to be able to focus on being in the room. And so to me, that was amazing that he could actually smile and that he was surprised. So sometimes, like with the case of TH, I realized that because he was sitting down and he felt the comfort level, I asked him that to stand up and to notice if anything had changed when he stood up. And when he stood up, TH related to me that it felt still a little bit uncomfortable, like almost like the suds had increased a little bit. So my intuition told me, let's repeat the process as you're standing up. So we did the process again. Okay, notice what happens in your body when I move the pointer slowly or away from you, and stay with the pleasant memories and follow the pointer. And very simple, I just went again. And as soon as I did several of these movements, he reported that he could move and he wasn't as discomfortable as he was before. So what I have learned with this process is that sometimes there are different memories as we're walking, as we're sitting, as we're bending, that might trigger again the sensations of discomfort. And so use your judgment, your clinical judgment, and test it and see how the client responds as you do the Z-axis within those movements. So I'm going to open right now the discussion to everybody in case anyone wants to ask me any questions so far about this.
We have some questions in the chat, so I'll read those first, and then people maybe can unmute themselves. So Maria, and probably most people also, would like to know, what if there was no memory of when there was no discomfort?
Okay, great question. Mm-hmm. So the only time that I encountered that, it was with chronic, someone who had been in intense pain all their life. But this is the beauty of our brain, of our body, is that even if we have never experienced the comfort, we have what we call the mirror neurons. And with mirror neurons, we're constantly watching and perceiving how other people are feeling. So in my experience, when you don't have a personal experience of comfort, I asked the client, have you ever seen a video of a snake just moving around, or the tentacles of a octopus? And they're like, yeah. I said, have you ever noticed if they're in pain or they have this experience discomfort? And I was like, no, they seem very flexible when they're swimming or they're moving around. And I said, what if you were to just focus on something like that and just think of your back, especially if they have issues with their lower back. Think of it as when you're focusing on the tentacles of the octopus moving around and swimming. Think of that and see what happens. So sometimes it's about the curiosity of, yeah, what would that feel like? And because of our mirror neurons, we might experience something very different, and that might be what helps the client. But it's really up to your creativity to think of that as well. I don't know if I have responded to that question.
Okay, and then Kayla just wanted some clarification if you are using the word comfort or pleasure when doing the setup.
Good. So I don't use the word pleasure because we do not trust pleasure, or at least most of us do not trust that word. So I tend to stay away from the word pleasure. I say comfort. That is the best word that I have found so far, that clients respond to that, because everybody wants comfort. You know, we all feel like we deserve some comfort, right? So that's the easiest. And also I like, because of the fact that comfort and discomfort is very related, and a lot of my clients, they experience discomfort in their lives and they know what that means. So it's much more available for them to access those tools.
So Eric, when you're doing this setup, like I understand you, when you were talking about comfort versus discomfort, and then finding a time when you had some state of comfort with that
Yeah.
area in the body. So the setup is in relation to that moment in time, or that memory, or now, as you said, like that snake movement or octopus movement, where you may have felt that, or you can sense or imagine what that might feel like. So in that terminology, as you're doing the setup to find that inside window, you're using the word comfort.
Correct. Yes.
Great.
That's the word that I use. Yeah.
And then can you also be more specific, or just restate, because a couple of people have the question about the z-axis. So you're going along the z-axis on that trajectory of whether
Correct.
more comfortable going forward or more comfortable going back, but wherever that initial movement is, you're going really tiny, slow, micro
slow movement. So you almost seem like you are not moving, but the client knows that it's moving, and the client is very intuitive. So you can see the eyes of the client just like moving, and you want to pay attention to everything the client is sensing at the moment, or that you can feel like something is going on here. And so you keep going slowly. Now, what I noticed is that the more you can get it further and further away, going all the way like to the ceiling on almost in a straight line, that usually tends to be the fastest. Now, I have to give you a caveat here, because I did this with a couple. So this couple came to see me, and they were fighting with each other. They were arguing. They came to see me for a couples therapy. And the woman had an injury in her arm. And so she had this band, she was holding her arm, and she had gone to the hospital. So she was in a lot of pain with it. And so at one moment when she was arguing, she felt the pain in her arm, and she was basically screaming about it. So immediately we did the z-axis, and she didn't feel anything, and she was like, "Oh, I don't feel anything." Oh, okay. So we kept doing the session, and at the end of the session, she was gonna grab a plastic bag with some sodas that they had in the plastic bag. She was gonna grab it with that arm, because she had forgotten that that was the injured arm. So I had to remind her, just because you don't have the sensation of discomfort, it doesn't mean your arm has been healed completely. So you want to be careful as well, so that your clients don't exacerbate just because they don't feel the discomfort. And so I was amazed, because she completely had forgotten that that was her discomfort, because she was feeling pretty comfortable in that arm. So that's the other element that you want to be able to remind your clients. Just because you don't feel something doesn't mean that it's healed.
So the clarification is, find the inside window spot that correlates with a comfort feeling.
Correct.
It's like a resource spot.
Correct.
And then we're working from that spot. We're not working with an activation spot also.
No. The only times that I have used the activation spot is if the sensations have been merged with emotions, where there might be an attachment to it, where there might be a secondary gain. A client of mine that came to see me, she's filing for disability, and she doesn't want to let it go, right? So okay, so let's deal with that. That might be another point that we might go to the activation spot of where do you feel that in your body, the need to keep it. But that's a whole different setup. But for a very simple setup, what I'm showing you right now, it works beautifully. Experience it. You will be amazed when you see the client saying, "Oh my gosh, what happened?" And it's just very simple. As long as we stay within the client experiencing the comfort memory, especially when they were using that part of their body, that actually they were using it in a comfortable way.
Can you speak to the phantom pain? Somebody was curious how this works with phantom pain. Have you worked with it?
I have not used it on phantom pain. With phantom pain, it's a completely different ball game because, as we all know, it's areas of our brain that have maps, that those maps have been activated. Because technically speaking, we're not sensing whenever we have pain or discomfort in a part of our area of our body, we're not sensing it there. We're sensing it at a much higher level, the thalamus and various other areas of our brain. So the same thing here with phantom pain. We're dealing with maps within areas of our brain that are still being activated. So think of it as phantom pain as the same thing with our eyes. If right now if I were to look at something and all of a sudden I close my eyes, I can still look at it differently, but I can still perceive it. So the same thing like that is being perceived someplace else, even though it might not be on my sight. So the same thing with phantom pain, but that's a very different experience.
Okay. And then just again, the clarification that we're moving the pointer only in the direction that feels more and more comfortable for the client.
Right. Yes, correct.
Okay.
So I have been asked the question before. So what do you do when there's entanglement discomfort? Let's just say the adverse childhood experience questionnaire tells you that the client scored a number of 3 or greater, indicating that they went through humiliations, sexual abuse, who knows, whatever happened in their lives. And the score says 3 or greater. So research has shown that whenever there's a 3 or greater, your chances of experiencing discomfort, chronic discomfort, is going to be increased a lot. So whenever you know that, whenever you give the ACE questionnaire, then you might be noticing, okay, has this discomfort been with you for a very long time? Yes. Can you tell me a little bit about that? This is what happened. Okay. And they might tell you a story about it, or their history with the association of discomfort and the emotions back in the day, of trauma or whatever, or neglect. So with that, I have discovered that, and this is so cool, that as long as the individuals have given you, or have they thought of a concept of what it means to them, the entanglement, or at least the experience of the trauma, and how they might even be curious of how this relates to pain or discomfort, that somehow, now this is my theory, that information is placed in a folder in our brain called the working explicit memory. And that as long as it's in that folder of working explicit memory, we don't need to revisit it anymore. And that somehow we're going to use a very different strategy. And this is what I want to teach you today, of this unique strategy that has helped individuals lower their discomfort. So let's just say that a client comes to me and says, I have had a history of sexual abuse, blah, 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 blah. And on top of that, I'm filing for disability, and I feel like I'm in constant pain. I can't sleep. Okay. So once we have done the ACE questionnaire and I ask the client, tell me a little bit or think of those areas that you feel like it's related to the discomfort you're feeling. And let's just say that the client is thinking about the brother that abused her, the individual who, the first spouse that mistreated her, whatever it was. I tell the client, don't tell me too much about it. I really don't need to know. I just want you to bring a little bit of that awareness, but then don't go there. Just put it there, because we only need to put it on that folder, that envelope of explicit memory, and that's all we need. And now what I do is I repeat the same process that I was doing with the Z-axis. But this time, what I'm including is that while I'm moving the pointer, I tell my client, from time to time, I'm gonna say the word blink. And your job is, when you hear the word blink and you're experiencing the comfort of you're playing the frisbee and taking your dog for a walk, or whatever memory it is, and when you hear the word blink, you close your eyes 3 times and you blink 3 times. But only when I say the word blink. So what I learned, or what I have experienced, is that somehow by doing the blinking as they're gazing and I'm moving the pointer, it's almost like it's doing a break state in the brain, and that whatever information was put in that folder, on the explicit memory folder, it almost like it gets evaporated. And then all of a sudden what I notice is that, oh my gosh, this is like pretty cool, especially for what we will call it chronic pain, because it's associated with something else. And my experience is that repeating this process and doing this with a client is probably the fastest way that I have worked with clients with chronic issues. And to me, it's fascinating. So I gotta tell you a story. Okay, so, and then I'm gonna be quiet. So I myself, you know, if I were to do the ACE questionnaire, I have a score of 3 from my childhood experience. So from time to time, I get whenever I'm going through a very stressful situation in my life, I experience lower back pain. And this is why I tested everything that I'm telling you. Is I'm testing it on myself. And if it doesn't work, then I don't use it. And I was paddleboarding at the lake. I would stand up paddleboard, and I was paddleboarding, and I could feel the discomfort in my lower back. So I know it's associated with some fears. I know it's associated with some irritation about something that is going on in my life, whatever it is. The only thing I know is that something is happening. So the first thing that I did, and this was cool, I stopped paddling. I was floating on my paddleboard, and I don't have a pointer at that moment, but I have my finger. So the first thing I did is I communicated with the part of me that was feeling that discomfort, and saying, okay, we're not going to reject it. We're going to accept it the way it is, whatever it is that I'm feeling. Maybe I'm afraid about something. Maybe I'm irritated about something. I really don't know specifically, but it's okay. And then what I did is I looked at my finger, and I'm pulling my finger away from me, because I know that that's what gives me comfort, especially when I feel like that I need the comfort at that moment. So I was thinking of the positive memory for me, which for me, positive memory is paddling, right? Because I'm moving my body. So I'm thinking of paddling, I'm already on the paddleboard, so it's very easy. So I just find the spot. So where is the spot? Right here. Okay, perfect. So I just focus on my finger, and I started pulling my finger away from me very slowly. And because it's associated with something else, another neural network, I blink my eyes, and I started blinking 3 times, and blink again, and blink again, and blink again. And I did it about 2 passes like that. And
Eric, let me just ask you a question. So
yes,
when you're pulling away, are you stopping at any point and then blinking, or you're just through that whole sweep blinking only 3 times?
exactly. I'm blinking, and I don't even, I blink randomly, as intuitively. I don't even count. I don't have a rules for that. It's more intuitively. And when I did that, I noticed that the lower back, it just feels pretty good. And I could actually move. And I started rotating. And then what I did is I went and did some squats to see how the lower back will feel. And I noticed something doing the squat. I felt a little discomfort. So I repeated it as I was doing the squat. I stood there when I was feeling the discomfort. Once again, I found the spot, and I noticed myself paddling, and I went blink, 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 blink again. Notice, I was like, oh, that feels pretty good. And so I was like, wow. So I just went, and actually what I did is I shortened my paddle for paddling, and I was going really, really, really fast because I was thinking, oh, it feels really good. But where I'm going with this is that I want all of you to experiment with this, because I feel like if you can come up with a better experience and an easier way to do things, it's going to help us, but it's going to help our clients, so that they could even be doing the same thing that I did on myself just by finding that spot. Mm-hmm. And then the other thing that I was thinking is, gosh, we are right now, because of COVID-19, we're all doing, telehealth like this.
Eric, before you go into this next example, I just feel mindful of the time.
Yes.
We have.
There's some hands that are raised. Brooke, if you want to go ahead and unmute yourself.
Yeah, I was just hoping you could kind of expand on what you were saying about saliva being a sign of the ventrovagal response, and then you connected some brain science after that, but I just didn't get it written down.
Okay, so what Dr. Ángel Escudero, and you could Google him, Ángel, and it's like spelled like angel, and then Escudero, Escudero. The way he talked to his patients before doing surgery is that our body, our brain, our neocortex and our subcortex are connected. And how we know they're connected is when we experience saliva in our mouths. When our mouths are dry, it's because we are either in parasympathetic, and so we are not in sympathetic nervous, and we are not connected. And so therefore, his very simple sign for him is, can you have some saliva in your mouth? Because that will give us that activates the ventral vagal nervous system. And one of the things that he shared with me was that when he's doing surgery, he hands a mirror. So he has one of those little mirrors to the patient, so that when the patient is is having the surgery, because the patient is awake, the patient is constantly seeing its eyes, but it's also noticing saliva. And as long as the patient knows I have saliva and I'm seeing myself on the mirror on my eyes, I can tell my body to feel comfort. And so he says that's all they need, and pretty much it works. And he has all these, he shows videos and all these photographs and everything of patients in which he had one patient singing. And the nurse said, "Do you remember that song when you were a child?" And it's such and such song in Spanish. And the lady says, "Yeah, I remember that song. How does it go?" And the lady started singing as she's looking at herself in the mirror. And you can see they're cutting on her. They're, doing all these procedures, and she doesn't feel anything. So what Dr. Scudero said is the ventral vagal response of our nervous system, our 10th cranial nerve, is sending information, and the only thing we need to do is get it activated through having a way of sensing that we have some control by, which is the saliva. And so that will be the quickest way that I can explain to you. And I'm sure there's all research on it, but you can read about it too.
So Beth, are you calling out? Caroline?
Hi. Sorry. I think I have this question. A number of people in the chat looks like has it too. So is there any rhyme or reason to when you tell them to blink? And when you did your example on yourself, you basically said blink, 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 kind of quickly in rapid succession. Is that how you're doing it with your clients as well? And are they continuing to blink on their own? Or are you telling them to hold their blinks only blink when you tell them to?
Good question. So use your intuition. Too much blinking is not good because they're doing 3 times. They're closing and opening their eyes. And in my experiences, the more random it is, the better it is. And the less you do it, the better it is too, so that you don't want to do it too much. But when I was doing it on my own, it was more intuitive because I knew when I needed it. And so I am noticing that I'm gaining something from it. And intuition tells me, time to blink. And I keep going and keep going and keep going, and time to blink. So that's when I do it. Now, I had one client that she closed her eyes. So I told her, when you hear the word blink, just open your eyes 3 times and close them. So do the opposite of it. And actually work for her that way. But notice how they're responding, because you can see them. If the client is having some facial expressions of surprise or whatever, that might be the time for you to do the blinking.
Darcy has a question.
Oh, I just clarify, a number of people keep asking, once you start on that inside window comfort spot, you ask them, is it more comfortable when I go towards you or away from you? If they say it's more comfortable going away, you keep sweeping towards more comfort.
Yes, correct. Yes. So if they tell me that no, because I have several clients, and that's the beauty of Brainspotting, we don't have a recipe. We don't assume. We just go where the client is, and we have the principle of uncertainty. We don't know what's going on, but the client does. And so I had this client that the opposite was the closer the pointer, the more comfort she was getting. So then I started all the way from the back, and I started coming because that's how she got the comfort. And I just told her, okay, just stay with that and see what happens. And I got as close as I can without invading too much her space. And then I went back again. And then I go fast when I go back, but I go very slowly when I'm coming back. So hopefully that responds.
Thank you. We do have only 1 more minute.
Darcy has a question. Go ahead, Darcy.
Hi, Eric. Thank you. I'm confused about the concept of the explicit memory folder in relation to the blinks.
Okay. So the only reason why I brought it up is because what I have learned is that whatever you put in that folder, something happens when you blink, where that almost like the folder in that explicit memory kind of evaporates it. So I'll tell you okay, so this is interesting. I made a list
Be mindful because we only have a minute.
Okay. I made a list of 7 things that was bothering me that day. I made a list. And so I put it and I started gazing. I took the number 1, which was the greatest thing that I was more worried about. And I had the suds very high on that. I did the blinking as I was finding the spot. And all the suds on the other items that I was concerned about, they didn't evaporate completely, but the suds went completely down. So if something was maybe a 7 down here or a 5 down here, now it was like a 2 or a 1. Something happened to it. I have no idea what. Some of you might have to figure it out.
Okay, thank you.
So this is such a rich, rich presentation. Thank you so much. I know that you wanted to share something about COVID and I don't know, Zoom. If you could do it like in 30 seconds, we'd love to hear it. But I wanted to do a quick shout out of deep gratitude for your wisdom, your clarity. We've sat and spoken about this before, but I can't wait to get on a paddleboard and try it. So.
Yes, come to Peachtree City. We'll go paddleboarding.
Absolutely. I'm excited.
Right. Yes, wonderful. It's an honor being here to all of you, and thank you for having me. And I'll make that available, all what I said to you, Cynthia, and then you could.
Yes, and if you have the information about what we can do with the Zoom and the COVID in that, now that we've heard all of this, that would be amazing, because I know that a lot of people are here looking forward to some relief every day and every moment. So
Wonderful.
Thanks.
Wonderful. I have to go, but thank you so much.
Blessed. Thank you.
Namaste.
Namaste. And I just wanted to thank everybody for your time and your attention and great inquiry questions. And if there's anything else that Eric is passing along, we have your contact information through the registration and we will pass it right out to you. Give us a few days though, please, for one person connecting with another. So Beth, do you want to do any closeouts?
I want to remind everyone that if you're a member of SEPI, you get all of our wonderful webinars for free. Our next webinar is July 9th, I believe. That's from a paper one. Yeah, and Christina Maridurosian, sorry, I just killed your name, is doing a training on brain spotting and dissociation, so don't miss it.
Okay. Thank you. And we'll post this recording as well. So have a great day. Bye.